in spine. He was in previously invited speakers to this webinar, and we are privileged to have him today talking about dura and tumor and the cavernous sinus and the surgical implication of it. It's yours.
Thank you, Imad. Thank you, Vlad. And I see several friends, several respected and wonderful friends in the audience. So I am going to talk to you about my lifetime work on cavernous sinus. Cavernous sinus is a subject of my great interest. And if you see my first slide, dura mater. Mater means mother. I've been talking about mother for a long time. And recently I've lost my mother, but my lectures hopefully will go on for some more time. So many of these articles I have discussed earlier in the literature. Sorry for this. In this book in 1996, I published. So I'm working with cavernous sinus for over 30 years. And in this book, most of the work was on cavernous sinus has been published, and Imad knows about my work and many of you know about my work. So I'm here to just summarize my thoughts. There are many articles which are very fantastic, beautiful articles, which I wish at least the young people can read. And many of these are on speculations, on philosophical issues, on role of cavernous sinus in eye movements, role of cavernous sinus in eye health, and several other things, role of cavernous sinus in regulating the pituitary gland, role of cavernous sinus in regulating the body heat and body temperature, and so many things. So here are some of those articles. Most beautiful things which I mention in my papers is one is that cavernous sinus has a great role in eye movement and a great, wonderful role in vision. And over the years, there are several articles on surgery of cavernous sinus, and I wish you have an opportunity to read them because many of these articles are quite old, more than 25, 30 years old, but they have been quite popular and very well cited. You will be surprised, Imad, and you know about this, that I got this word from Arabic legacy, alum al-dimag. And Sam al-Mefti was very happy to hear my first presentation, which I gave more than 30 years ago. Alum al-dimag is from Arabic world, and it means that meninges are the mother of brain. So dura mater word came later. Arabic word came much, much before that. So dura is indeed durable. And if you see, the whole brain is in a compact dural cavity. There is a whole world of zoo in the nasopharyngeal cavity in the ear. So many microbes, but the dura keeps this whole cavity sterile. This is impermeable. Nothing can enter into the dura. No coronavirus has ever been reported to enter into the brain. So this is a compact. And this goes along the nerves, along the vessels, this dura goes. This has to be understood very nicely. So cavernous sinus is located by the side of pituitary gland, by the side of paranasal sinuses, and it is a compact cavity. It is extradural and within the dura. So it is both extradural and within the dura. These cranial nerve 3, 4, V1, V2 are having their own dural compartment. And this has to be understood, very fantastically understood. So my experience in cavernous sinus surgery, you see, 1993, I did this case with extensive pityosectomy and extensive exposure. 1995, so 25 years ago, I did this case with very radical resection. 1995, I left this tumor behind. There was no gamma knife. There was gamma knife at that time, but there was nothing given to this particular patient. This is another patient which I operated 23 years ago and several years ago, quite well and quite asymptomatic. So we have to learn cavernous sinus surgery. You cannot say, I don't want to learn cavernous sinus surgery. Cavernous sinus surgery is philosophy. Cavernous sinus surgery is anatomy. Cavernous sinus surgery is art that we have to understand. So for your information, this was the first article in the literature on extradural approach to intracavernous sinus tumors. Of course, Vinko Dollans described intracavernous aneurysms. He described extradural approach. He also described trigeminal neuronoma extradural approach. But this article, intracavernous sinus tumor, in 1997 was the first article in the world literature. So I want to give you some tumors. This is intracavernous hemangioma. This is the only tumor which is primarily intracavernous. So as it grows, it respects the dura. It does not transgress the dura. It goes towards the sella through intercavernous dural connections. So this is completely within the dura. It goes towards the orbit, goes towards the Meckel cave, and it is absolutely benign tumor, but absolutely difficult to resect because it is very heavily vascular. And in 1991, I did this about 30 years ago, and this was among the first cases in the world literature where preoperative and postoperative images were shown in the published article. So this respects the dura. No matter how big it becomes, the dural lateral wall remains, Meckel cave, orbit, goes towards the sella, intercavernous connection, carotid arteries encased, heavily vascular tumor, and there is angiographically occult, and you have to remove because there are select indications. So in 2000, we described extradural approach to cavernous hemangioma on the premise of these dural connections. So these are extradural. Dura remains intact. You have to come like this. These are benign tumor. Brain is not tight, and you can come extradural, open the dura, open the lateral wall. Between the trigeminal nerve, you have to dissect, and you have to remove these tumors. So 2000 we described. Now we have experience of 39 or 40 cases, and which is quite a large experience. These are not very common tumors. So this is another tumor you can see towards the sella, lateral wall respected. It respects the mother dura. So this is one video which I will not show. So you see, this is preoperative. There is third nerve weakness. There is lateral nerve, and you can restore the vision. You can restore the eye movements. And this is the only treatment. More important is you can bring the smile, because there is huge headache in these patients of cavernous hemangioma. So this is another case I would like to briefly show you, because I sometimes run over the time. And this is gasserian ganglion, extradural exposure. I'm opening the gasserian ganglion. So this is a transgasserian ganglion approach for these tumors, which are completely intracavernous sinus. That has to be understood. So you have to then work. You see, this is intracavernous carotid artery, very heavily vascular tumor. You have to resect the tumor. You have to control the bleeding, and it can be done beautifully. You do it, you cure. Absolutely, sixth nerve has to be protected throughout the operation. And of course, I don't have time to go into technical details of this subject, which is a very beautiful chapter of cavernous sinus surgery. So this is pre-op and this is post-op. Now I want to go and show you how the pituitary tumors behave with the dura and how they respect the dura. And believe me, some of these work which I am presenting, which is heavily published, has completely revolutionized pituitary tumor surgery. And you will ask me how. Let me show you how. So these are the pituitary tumors which can grow huge sometimes, but they remain benign. They remain benign, and if you resect, you can give new life to these people. They are not cancers. They are benign. First important thing that we described for the first time in the literature 25 years ago, that pituitary tumor, as it grows, it elevates the dura along. This is the diaphragm celli dura, which can go, which is elevated. So there is nothing within the tumor. This concept has completely changed pituitary tumor surgery. Otherwise, 25 years ago, all these tumors were operated transcranially. So there is a dura. So you remove the tumor, the dura will ultimately land into the picture. This kind of nubbin is also dural nubbin. It is not intracranial, it is not intradural. This nubbin is within the dura. So you have to understand. If you have to resect, you have to understand. It is not inside the brainstem. Of course, it is inside the brainstem, but there is a dural protection. This is very, very important. Grade 2 is when it goes into cavernous sinus, the lateral dural wall is intact. It encases the internal carotid artery. Diaphragm is intact, lateral dural wall is intact. Has to be understood if you have to do this. It can be stretched, lateral wall can be stretched, but cannot be transgressed. They respect the mother dura. Now you see this beautiful slide. Intracavernous extension, lateral wall is intact. Beautiful slide. Dural roof is elevated, dura. So it is diaphragm, this is dura of the roof of cavernous sinus. Dura of the roof of cavernous sinus. Dura of diaphragm, dura of roof of cavernous sinus. You see very clearly seen diaphragm, dural roof of the cavernous sinus. If you have to do these tumors, this anatomy has to be understood. Dural roof, diaphragm, dural roof of cavernous sinus. Grade 4 tumors are when it transgresses the mother dura, when it behaves irrationally and irrelevantly or aggressively. I call these people who do not respect the mother as aggressive children or aggressive tumors. So this is my grading scale. The dura is intact, lateral wall is intact, dural roof is elevated, and when the arteries of circle of Willis is elevated, that is grade 4. These are malignant tumors, rest of them are benign. This diaphragm celli anatomy, in my estimation, has completely changed the face of pituitary tumor surgery. This concept was not there earlier in the literature. You see this tumor, diaphragm is elevated, you break into the tumor, and you can very quickly resect this tumor and the diaphragm will come into picture. I did this in 1997. So like uterus, the baby will be pushed by the uterus. Similarly, the diaphragm will push the tumor down. You have to understand this concept. You see, this is a pregnant tumor. You remove the baby first and the mother itself will come down and subject herself to you. This is post-operative in 2000, 20 years ago. This tumor, quite straightforward, if you know one concept, that the diaphragm is intact. If you have this concept, this subfrontal extension, no need for transcranial surgery. In 15 minutes, you can remove this tumor. No need to remove the tuberculum celli or planum spinalis, just anterior wall. Demolish the tumor, the dura will be like this and can be removed. No matter how extensively it goes, you can remove this tumor from the nose. Whether you use endoscope or whether you use micro, that is very minuscule of a problem. You see this tumor, 20 years ago, I removed this tumor by the concept that the diaphragm is intact and this is post-operative. And in a very quick time, this is another tumor I operated. You see this dura is intact and this is post-operative image. Cavernous sinus is a different issue. When to remove, when not to remove, and how to remove is an issue. But one must understand the dural anatomy of this tumor. The fact that dura is elevated has to be understood. If you have this concept, you can remove this and you can go from the cavernous, from the sella into the cavernous sinus and go into the under the roof of cavernous sinus dura. This anatomy is most beautiful anatomy, and how to do and what to do these kind of tumor is a different issue. Now I will show you another benign tumor, trigeminal neurinoma. In 2003, I published 73 cases of trigeminal neurinoma. Now my series is nearing 300 cases. First time I published that trigeminal neurinomas arise from the Meckel's cave. They arise and they remain within the dura of the lateral wall of cavernous sinus. In the year 2003, I said that this part of the tumor is subarachnoid. But this concept later changed because later I published that even this part of the tumor can be interdural in several cases. So you work within the dura here and also work within the dura or work under the arachnoid, respect the mother dura, respect the mother arachnoid, and you can do fantastic and quick job. In 1995, I described interdural approach. So during those times, these tumors were very difficult to operate. So I did this kind of exposure, just opened the Michael's foramen ovale, worked within the dura and removed these tumors. In 1994, I did this. In 1995, I removed this tumor working within the dura without doing any craniotomy. Even the tumor which extended into the posterior cranial fossa, I did it without craniotomy, just doing the lateral dural wall of foramen ovale and working within these pictures were published in my article in 1995. This is another picture from the same article without opening the skull. So this tumor remains within the dura. If you have this anatomy, this is an easy tumor to remove, and you can remove in very quick time. And many of these posterior fossa component is also within the dura. In 1991, I did this in 2 stages. You see, though at that time, 30 years ago, these tumors were removed in 2 stages. So this is posterior fossa, then middle fossa, and this is 2-stage. But when we, as skull-based surgery advanced, contributions from various people like Leonard Mallis, Hakuba, and Lullingham Shaker, and these kind of people who completely revolutionized this field. So this is roof of I used to do this kind of basal work at that time, but as I advance further in my experience, I do just this little bit of exposure, little bit of craniotomy, subtemporal, basal subtemporal exposure for many of these tumors, and 1-stage exposure. Open the dura, work within the cranial nerves, and then demolish the tumor. We young neurosurgeons have to learn, not young, everybody has to learn how to demolish these tumors, and you can do a fantastic job and a quick job. If you do not know this anatomy of dura, you may do proximal exposure, distal exposure, and you will never be able to reach the area. Quick exposure, radical resection, complete cure, and for the first time in the literature, we described that you can improve the sensation of the 5th nerve following these tumor resection. Even when the tumor goes extracranially, they are within the dura. This anatomy you have to know. And when you know this anatomy, you can do transcranial or extracranial, and there is no cranial nerve or no artery within the tumor. This anatomy is very clearly has to be understood. Like trigeminal neurinoma, C2 neurinoma is very parallel. Vertebral artery here, carotid here, cavernous sinus here, huge venous plexus. This tumor also remains within the dura. So this was my understanding several years ago, that this part is intradural and this is interdural, like trigeminal neurinoma. I published this in 2008, 60 cases where I said this is intradural. In 2018, I said that even this is interdural. Work within the dura and you can do a very rapid job and quick resection like trigeminal neurinoma. C2 neurinomas can be removed beautifully by one premise, that dura remains intact. This is third nerve tumor. Third nerve tumor is interdural within the confines of dura. No matter how dangerous it looks, how difficult it looks, if you know that there is a dura, it is not the capsule of the tumor. You don't have to remove the dura. Work within the tumor, learn the art of demolishing the tumor, and you can save the third nerve function or improve the third nerve function if you know that these tumors are surrounded by dura. You see, they arise from the oculomotor cistern, open up the dura and elevate the dura, and surrounded by the dura. This is not capsule. And this is a beautiful anatomy that you have to understand. There is a dura around the third nerve. And if you know this anatomy, you can improve the function. 6th nerve neurinoma is intracavernous sinus. I am still learning on these tumors, and I will come back to you very soon on these tumors. 7th nerve tumor arises from the geniculate ganglion. Beautiful anatomy. You must know this anatomy. Geniculate ganglion, and they remain within the dura. If you know this anatomy, that the whole thing is under the dura, you come from lateral, open the dura, and you can improve the 7th nerve function. Nobody in the world has described this. And there is a possibility, interdural approach, and you can have a quick exposure, radical resection, and a beautiful resection. So you must remember this, that these tumors are skull-based tumors, difficult tumors, but philosophical. They respect the mother dura. Similarly, lower cranial nerve tumor, they are interdural. Beautiful, you have to know this anatomy. You see, this tumor is completely within the dura. Work within the dura, work within the dura. Don't go outside the dura. You can improve the function of the lower cranial nerves. Even when the tumor goes outside, there is a well-defined dural anatomy around. And this anatomy is absolutely critical if you want to improve the function. If you remove the dura, considering that it is capsule, you have demolished the patient. Now I want to show you chordomas. Chordomas are extradural tumors. They completely, dura will remain.
Just to let you know, Atul, 2 minutes.
Okay. But you gave me 20 minutes or you gave me less, Imad?
I gave you 22 minutes. So
I
you
have 2
have
minutes
2 minutes
left.
left.
Okay,
Yeah.
you stop me, because I cannot stop, you know me. So these tumors are extradural. Dura is respected. Cavernous carotid is displaced anteriorly by the tumor. Very beautiful. Cavernous sinus is displaced superiorly by tumor. So this anatomy, if you know, you can do wonders with this tumor by coming from lateral and removing dura will be intact here. So this tumor, I published this article in 1995. This artery is displaced anteriorly. The whole thing is without any artery. Work within the tumor and you can do a beautiful resection. So I described this approach, middle fossa subgastrin ganglion approach to these kind of tumors. And this tumor, you see the carotid artery is anterior. You must know that the dura is present here. Work within the dura, and you can do a quick job and a very beautiful job for these tumors. Recently, I described supracerebellar approach for clival chordoma. This tumor, of course, you can come from nose, you can come from lateral, but I removed this tumor from here. Why I removed from here? Because the sixth nerve comes under my control and I can save the sixth nerve function and beautifully resect this tumor. Both sixth nerve under my control, hold proximal, and then demolish these tumors. And this is the post-operative resection. So I don't want to go too much on cavernous sinus meningioma, but I want to show you that these tumors, cavernous meningioma has a different world of cavernous meningioma, but unfortunately due to time, I cannot show you much. But many of these petroclival tumors, I described the supracerebellar approach for the first time in the literature, and it has become very popular approach in the world of petroclival tumor surgery. And I hope and I wish and I am sure that you know of this approach because Vlad is very familiar, Dr.
You are
Vladimir
right.
Beres. And so thank you very
This is
much.
his baby. He likes it. Thank you very
Yes,
much,
he
Atul,
likes it.
for the
Thank
wonderful
you,
presentation.
Imad. And I hope young neurosurgeons in the audience will try to understand the anatomy of the region. That is one. Second thing is anatomy of the tumor, which is number two, and the more important. And each tumor has its original discrete identity that has to be loved, respected, and then the operation has to be conducted. Thank you very much, Imad.
Thank you, Atul. You are always a favorite invitee to the faculty of this webinar and
Thank you.
to share